Welcome to Rheumatology Board Review Part 2. I'm Jörg Ehrman. I'm a rheumatologist at Brigham and Women's Hospital and instructor in medicine at Harvard Medical School. Question number 11. A 45-year-old male presents with painful swelling of the third and fourth toe of the right foot and a rash under the soles of his feet for 4 weeks. He denies fever, recent dysuria, diarrhea, eye problems, or a history of psoriasis or back pain. He's sexually active. He takes no medications. On exam, he has dactylitis of the right third and fourth toes, and there's a yellow-brown nodular hyperkeratotic crusty rash under both feet. He has a borderline CRP. The CBC is unremarkable, and the X-ray of his feet only shows soft tissue swelling, but no destruction. The next slide shows an image of a rash similar to what the patient in the clinical vignette had. Now, which of the following is the most appropriate diagnostic test in this patient? A, anti-CCP, B, an anti-nuclear antibody test, ANA, C, a urine PCR test for chlamydia, D, an HLA-B27, or E, an X-ray of the pelvis. And the correct answer is C, a urine PCR for chlamydia. Based on the clinical vignette, the working diagnosis for this patient should be reactive arthritis. Reactive arthritis is a type of spondyloarthritis that begins acutely within 4 weeks after a urinary tract infection or episode of infectious diarrhea. And the microorganisms associated with reactive arthritis are chlamydia, Yersinia, Salmonella, Shigella, and Campylobacter. Synovial fluid aspirates, if obtained from a swollen joint in a patient with reactive arthritis, are negative for gram stain and culture by definition. Reactive arthritis is in about 50% of cases self-limited. In the other 50%, the acute arthritis may become chronic. Clinically, reactive arthritis has features also seen in other types of spondyloarthritis. So asymmetric oligoarthritis, enthesitis, dactylitis can be found. Patients who have axial disease will have sacroiliitis, and then reactive arthritis is also associated with specific types of skin inflammation, namely keratoderma blennorrhagica and sursnate balanitis. And the patient in the vignette had dactylitis in 2 toes, plus what looks like keratoderma. So the working diagnosis for this patient would be reactive arthritis. He does not have features suggesting rheumatoid arthritis, lupus, and he does not have back pain to suggest axial spondyloarthritis. It is important to test him for chlamydia because this is a sexually transmitted disease and would require antibiotic treatment because of that. Otherwise, there is no role for antibiotics in the treatment of reactive arthritis. Treatment is in the acute phase with nonsteroidals, and DMARDs are added in patients who develop chronic disease. HLA-B27 was one of the options in the question. And it was not the correct answer for this patient, but it does play an important role in the diagnosis of patients, in particular with axial spondyloarthritis. However, it is important to realize that HLA-B27 as a genetic marker is present in the overall US population, 6.1% overall, slightly higher in non-Hispanic whites, slightly lower in Mexican Americans and non-Hispanic blacks. So HLA-B27, although it is very strongly associated with spondyloarthritis, in particular with ankylosing spondylitis, it never makes a diagnosis. It can only be supportive of a diagnosis of spondyloarthritis. Question 12. A 28-year-old male presents with chronic pain in the low back and buttocks for about 3 years. The pain is worse in the morning and associated with stiffness. Symptoms improve with exercise. Ibuprofen provides some relief. The patient denies peripheral joint pain or swelling, rashes, GI complaints, or eye symptoms. He has a sibling with psoriasis. On exam, there's tenderness to palpation over the sacroiliac joints. The exam is otherwise unremarkable. Range of motion in the lumbar spine is normal. The patient is HLA-B27 negative. CRP is 7 milligrams per liter. There's no evidence for sacroiliitis on pelvic X-ray. The question is, what is the most appropriate diagnostic test in this patient? A, an X-ray of the cervical, thoracic, and lumbar spine. CT of the pelvis, B. C, an ultrasound of the sacroiliac joints. D, an MRI of the sacroiliac joints. Or E, a technetium bone scan. And the correct answer is D, an MRI of the SI joints. This patient presents with chronic back pain and features of inflammatory back pain. Inflammatory back pain is a constellation of back pain features that include insidious onset, association with morning stiffness, improvement with exercise but not with rest. Inflammatory back pain typically responds well to nonsteroidals, and it may be associated with buttock pain that may also shift between left and right. Inflammatory back pain is a characteristic feature of axial spondyloarthritis. Axial spondyloarthritis is a relatively new disease entity. It includes patients with classical ankylosing spondylitis, plus other patients who have similar symptoms but have non-radiographic disease. This means that when you obtain X-rays of the sacroiliac joints or spine, the typical and classical features of ankylosing spondylitis are absent. In this situation, then, if there's clinical suspicion for axial spondyloarthritis, the next step after radiographs of the SI joints is to obtain an MRI of the SI joints. And this slide here shows the classification criteria that are used to define axial spondyloarthritis. They are classification criteria and should therefore not be used to make a diagnosis, but they can provide some guidance because they describe the phenotype of patients with this condition. And this is an MRI of a patient with axial spondyloarthritis. This is an axial section showing the sacroiliac joints, and on this fluid-sensitive stir sequence, there is white signal surrounding both SI joints here as well as here and on the left side. This is bone marrow edema, the sign of sacroiliitis in this patient. I want to make a point that very important that I forgot to make when we looked at this slide. Axial spondyloarthritis is a condition without sex predilection. So it's equally common in men and women, in contrast to ankylosing spondylitis, which is 2 to 3 times more common in men. So this is a diagnosis, axial spondyloarthritis is a diagnosis that is easily missed in women if one doesn't think about it. Question 13. A 29-year-old male with ankylosing spondylitis diagnosed 2 years ago presents with worsening low back pain and buttock pain over the last 6 months. Morning stiffness lasts 3 hours. Review of systems is negative except for fatigue. Symptoms had previously been well controlled with physical therapy and naproxen. A switch to indomethacin 50 milligrams 3 times a day 1 month ago was without benefit. On exam, there is tenderness to palpation over the SI joints. The Schober test is 4 centimeters. The exam is otherwise unremarkable. The serum CRP is 10 milligrams per liter. The question is, what is the most appropriate addition to this patient's medical therapy? A, tramadol, B, methotrexate, C, sulfasalazine, D, adalimumab, or E, prednisone. And the correct answer is D, adalimumab, which is a TNF inhibitor. And that would be the next step in treating this patient. Ankylosing spondylitis is an inflammatory disease and therefore requires treatment with anti-inflammatory medication and not pain medications such as tramadol. Interestingly, a number of medications that are used to treat peripheral arthritis, in particular rheumatoid arthritis, are not effective in axial spondyloarthritis or AS, and that includes methotrexate, sulfasalazine, and also prednisone. So therefore, in patients whose symptoms are not controlled with nonsteroidals, the next step would be to start a biologic. And the 2 types of biologics that have been shown to be efficacious in patients with ankylosing spondylitis or more broadly axial spondyloarthritis are the TNF inhibitors and the inhibitors of interleukin 17A. Question 14. A 45-year-old high school teacher is evaluated for low back pain that started insidiously 3 weeks ago and has become worse over the last week. It is now constant, worse with movements, and does not respond to over-the-counter ibuprofen. He denies a history of trauma, malignancy, fever, weight loss, numbness, tingling, or weakness in the legs, bowel or bladder symptoms. He does not use IV drugs. On exam, the patient is very uncomfortable and there is reduced range of motion in the lumbar spine. Sensation, strength, and deep tendon reflexes in the legs are symmetric and within normal limits. The straight leg raise test produces lumbar pain. What is the most appropriate next step? A, obtain an X-ray of the lumbar spine. B, order an MRI of the lumbar spine. C, prescribe a corticosteroid taper. D, prescribe bed rest for 3 days followed by a graded exercise program. Or E, change the NSAID. And the correct answer is E, change the NSAID. This patient presents with symptoms that fall into the category of non-specific low back pain. So this is acute back pain without any evidence for a serious underlying condition. So review of systems in his case was negative for a serious underlying condition. And in this situation, imaging is not recommended because most patients will improve with a bit of time. And in many cases, a precise underlying condition would be difficult to identify. So in the absence of any symptoms or signs suggesting a serious underlying condition, the patient should be managed with education and reassurance. Non-pharmacological measures such as superficial heat or other approaches play an important role, and pharmacologically, NSAIDs and muscle relaxants can be given. And of all the options in the question, change the NSAID was the only or most appropriate answer here. It is important to give NSAIDs at full strength, unless obviously there are contraindications to these medications. Question 15. A 44-year-old colleague sees you for left shoulder pain. She is an avid tennis player and has had pain in the left deltoid area for the past 3 weeks. The pain is worse with movements and has prevented her from playing tennis. On exam, there is subacromial tenderness. The acromioclavicular joint is non-tender. There's full passive range of motion in the glenohumeral joint. Resisted shoulder abduction causes pain, but there is no weakness. Resisted forearm flexion is unremarkable and does not cause pain. The X-ray of the shoulder is unremarkable. What is the most likely diagnosis? A, supraspinatus tendinitis. B, rotator cuff tear. C, bicipital tendinitis. D, calcific tendinitis. Or E, AC joint sprain. And the correct diagnosis is supraspinatus tendinitis. Why is this the most likely diagnosis? So the patient has no tenderness to palpation of the AC joint, which makes this a less likely diagnosis. There's also no pain on resisted forearm flexion, making bicipital tendinitis less likely. The radiograph of the shoulder did not show any calcific deposits, ruling out calcific tendinitis, which leaves us with rotator cuff tear and supraspinatus tendinitis. The more likely answer in this situation here is supraspinatus tendinitis, because a rotator cuff tear, in particular if it's a full thickness tear, would be associated with weakness, and there was no mentioning of this in the clinical vignette. So supraspinatus tendinitis is the most likely diagnosis. On this cartoon here, we see the broad categories of conditions that can present with shoulder pain. In addition to diseases affecting the AC joint or the glenohumeral joint itself, such as osteoarthritis or crystal-induced arthritis, several conditions affecting the soft tissue structures around the shoulder can cause pain, including supraspinatus tendinitis or subacromial bursitis. Moreover, shoulder pain can also be the result of a cervical radiculopathy with pain radiating to the shoulder, or the patient may have referred pain because of an internal organ disease, gallbladder for the right shoulder, or heart disease could present with pain in the left shoulder. Question 16. A 25-year-old female presents with episodic painful color changes in her hands. This started after she moved to Boston 3 years ago to attend graduate school. Episodes are triggered by cold exposure. Typically, her fingers turn white and later blue. She has no relevant past medical history and takes no medications except for birth control. She feels chronically fatigued. Review of systems is otherwise unremarkable, which means that she denies joint pain or swelling, rashes, photosensitivity, dry eyes or dry mouth, mucosal lesions, shortness of breath, or weakness. Physical examination is unremarkable. What is the next step in evaluating this patient? A, perform nail fold capillary microscopy. B, check an ANA. C, check antiphospholipid antibodies. D, check scleroderma antibodies. Or D or E, no additional tests are needed. And the correct answer is A, perform nail fold capillary microscopy. So this patient clearly presents with Raynaud's phenomenon. It's a young woman, and so it is more likely that she has primary Raynaud's rather than secondary Raynaud's. And there's nothing in the vignette that suggests that she has lupus, an antiphospholipid antibody syndrome, or scleroderma. So from that perspective, there is no indication to check the antibodies in B, C, or D. Nail fold capillary microscopy is a cheap test that can be performed while the patient is in the exam room, and it has a high prognostic value for the development of a connective tissue disease, and so that would be the correct answer in this patient. So these are examples for Raynaud's, and then at the bottom part of the slide, you see either normal nail fold capillaries or abnormal capillaries with dropouts or these giant loops of blood vessels. So this is something that one would see in a connective tissue disease, for instance, in systemic sclerosis, where it would look like that. Question 17. A 52-year-old man presents with several episodes of hemoptysis over the past day. He had been well until 3 weeks ago when he developed myalgia, arthralgia, epistaxis, and diminished hearing. 1 week ago, he developed a rash and weakness in his right hand. Past medical history is otherwise unremarkable. The patient takes no medications. On exam, he has a temperature of 104 Fahrenheit. He has bilateral conjunctival injections, tender maxillary sinuses. There's decreased hearing in both ears. On auscultation of the lungs, there are diffuse rhonchi. He has reduced grip strength in the right hand, and there are palpable purpura over the lower extremities. Laboratory shows mild leukocytosis. He has an elevated ESR. Creatinine is elevated at 2.1, and the urinalysis shows 3+ protein with 50 red blood cells, 20 white blood cells, and mixed cellular casts. Which of the following tests is most likely to establish the diagnosis in this patient? A, anti-dsDNA antibodies. B, cryoglobulins. C, complement levels, C3 and C4. D, an ANCA. Or E, urine electrophoresis. And the correct answer is D, ANCA. This clinical presentation is the presentation of a patient with granulomatosis with polyangiitis. Disease manifestations include kidney disease, neuropathy, small vessel vasculitis with palpable purpura, and he also has involvement of the lungs and upper airways. And the condition that could cover all these different disease manifestations is GPA, whereas lupus or cryoglobulinic vasculitis or would not present with this complex picture. ANCA testing can be very useful, in particular when the results are strongly positive. Just as a reminder, there are C and P ANCA antibodies, cytoplasmic and perinuclear, and the C ANCA is more specific than the P ANCA. These antibodies can be tested either by immunofluorescence or using ELISAs, and here the P ANCA corresponds to the anti-MPO myeloperoxidase antibody, and the anti-proteinase 3 corresponds to the C ANCA. The ANCA-associated vasculitides are GPA, MPA, and EGPA, and the GPA in particular is associated with a C ANCA. This slide is just for review of the broad categories of different types of vasculitis. Large vessel vasculitides are giant cell arteritis and Takayasu, medium vessel vasculitides, polyarteritis nodosa, and Kawasaki disease. And then there is a larger family of different types of small vessel vasculitides, including the ANCA-associated vasculitides. Question 18. The anti-Rho antibody is associated with all of the following except A, Sjogren's syndrome, B, neonatal lupus, C, subacute cutaneous lupus, D, diffuse proliferative glomerulonephritis, or E, congenital heart block. And the correct answer is D, diffuse proliferative glomerulonephritis. This is a disease manifestation of SLE, which is not associated with anti-Rho, but with anti-dsDNA antibodies, whereas all the other disease manifestations are associated with an anti-Rho antibody. Question 19. A 69-year-old woman is admitted to the hospital with increasing shortness of breath on exertion. The patient has a long history of Raynaud's and was told to have scleroderma several years ago. She has lost 30 pounds over the last year in the setting of dysphagia. Facial telangiectasias and sclerodactyly are clearly present. While obtaining the history, you consider the differences between diffuse and limited cutaneous systemic sclerosis. Which of the following is a characteristic feature of limited cutaneous systemic sclerosis? A, skin involvement of proximal limbs and trunk. B, interstitial lung disease. C, pulmonary hypertension. D, an increased risk for scleroderma renal crisis. Or E, anti-SCL70 antibodies. And the correct answer is C, pulmonary hypertension. So clearly, A is incorrect because skin involvement of the proximal limbs and trunk is a feature of diffuse cutaneous systemic sclerosis. But also the options B, D, and E are features of diffuse disease, whereas only C, pulmonary hypertension, is a characteristic of limited to cutaneous systemic sclerosis. Question 20. A 23-year-old female college student is seen in the ER for acute bilateral ankle swelling and pain over both shins for 5 days. Symptoms have been getting worse, and she has now difficulties walking. She denies any trauma or recent travel. She has no significant past medical history. On exam, She is febrile. She has bilateral swelling of the ankles associated with diffuse tenderness, and there are bilateral lesions over the lying the tibias that are painful to palpation. Hematocrit is borderline, and these are slightly elevated. And this is a picture of these lesions. So you see these slightly raised erythematous bumpy lesions on the patient's legs. And the question is, what would you order next? A, chest X-ray, B, a skin biopsy, C, an ACE level, D, rheumatoid factor, or E, urinalysis and ANCA. And the correct answer is A, a chest X-ray. This patient presents with erythema nodosum and ankle arthritis. And the classical triad of erythema nodosum, bilateral hyaline-lymphadenopathy, and ankle arthritis is called Löfgren syndrome, and is a manifestation of sarcoidosis. So given that she has erythema nodosum and ankle arthritis, and no other features suggesting an alternative explanation for her erythema nodosum, the first thing to do would be to obtain an X-ray of the chest to look for hilar lymphadenopathy. Because if that is present, the diagnosis is essentially made. First-line treatment of Löfgren syndrome is with non-steroidals. And on this slide here, we see the hilar lymphadenopathy in a patient with a similar presentation. And this is the end of part 2 of the rheumatology board review, and I've included a few references for your reading.